We have seen a growing number of uninsured patients coming in, particularly in that age group of 40 to 49. For us, it tends to be more of our undocumented population that we're seeing coming in. And so for us, we are addressing it in two ways. One, we try to obtain grants as much as possible to cover the cost of screening for our uninsured population. And that allowed us to offer stool-based tests for free for that group. If grants aren't available, sometimes our health center is able to offset the cost of the stool-based test to make it more affordable for our patients to get screened. And in addition to that, we also work with our public hospital that offers a sliding fee scale for services over there. And so we can help our patients get qualified for the reduced fee services or the sliding fee services at the hospital, which will then allow them to get colonoscopies there as well. So between grants, our health center offsetting the cost of stool-based testing, or assisting our patients with the sliding fee scale for our public hospitals, how we've been able to address it. But in large part, it's been the grants that have helped us. We went about establishing open access endoscopy programs through a partnership with other community organizations. So one, we have a state roundtable. It's called the Louisiana Colorectal Roundtable that we work closely with. There's another local community group called 504 Health Net, which is a group of, it's a partnership between safety net providers here in New Orleans, so health clinics, hospitals, and others. And being a part of that group allowed us to learn more about what hospitals were already doing in the community and what some of our GI groups were offering in the community. And so they had already begun an open access endoscopy program within their system. We just weren't aware of it. And so working with the roundtable, working with our American Cancer Society partners, and through this group called 504 Health Net, we were able to learn of their open access programs and able to have separate meetings with them to find out how we can make it a win-win proposition for both organizations. And so that will be my recommendation for other groups, is to, if you have roundtables that exist in your state, definitely reach out to them. If not, I know the American Cancer Society has representatives throughout each state that are working in partnership with hospitals and clinics, and they can sometimes put you in contact with GI groups or surgical groups that are offering open access endoscopy programs and help facilitate that meeting. And for us, we just needed a facilitation of the meeting, knowing who to talk to and know that who was interested in that sort of partnership. The key to our success, it wasn't one, there were several keys. One was consistency. Once we finally developed the right strategy for our patients, for our clinic, we had to be consistent year after year. And that was probably the most challenging. But it was every year reminding patients of their need to be screened. And as I mentioned earlier, our approach was a stool-based approach, which is great because that's one of the fastest ways to increase screening. The downside is that you have to repeat that screening every single year. So the approach we took required an annual update. And so it was challenging for us because every year we had to sit down with the patient again and discuss the importance of screening. And what we found is that, as easy as it may sound to tell the patient how to complete the process, some patients were just very reluctant to do it. Not intentional, but they would just forget. So they would take the fit kit home and they would put it in the bathroom and just forget about it, or they would lose it. And so some patients, we would have to give them 2 and 3 fit kits throughout the year and remind them all year long, and still come December, had to kind of add a little bit more urgency to the process of having it done. So I think for us, it was just consistency. We just kept colorectal cancer screening as one of our top priorities or top performance indicators every year. So it kept it on our providers' radar, it kept it on our staff's radar, and it kept it in our patient's mind. The other key was opportunistic screening, or a global screening, where every time a patient came into our practice that was eligible for screening and that was not up to date with their screening, we had a discussion with them about colorectal cancer screening. And so they would hear it 3 to 4 times a year. And so because they kept hearing that message, to them, it was important because we kept bringing it up. And what we found over the years, because we've been doing this now since 2012, what we've learned over the years is that now that patients have gone through the FIT screening for 2 or 3 years or 4 years, they are now comfortable with having a colonoscopy performed. So some of those patients that were absolutely against colonoscopy screening in the very beginning, 3 years down the road are now open to the idea of having the colonoscopy screening performed. And that's something that we can anticipate in the very beginning, but something we've learned through the process that some patients, it just takes a while for them to warm up to the idea of being screened for colorectal cancer. One of the things that I like to say is that there's nothing about colorectal cancer screening that is attractive, that's sexy, that's interesting to talk about. You're talking about cancer, we're talking about the colon, we're talking about sticking a camera inside someone's rectum, we're talking about manipulating stool. There's nothing about the conversation that you can make interesting, appealing, or interesting to patients. It's just not. And most patients don't want to talk about it, they don't want to think about it. And so we've learned the hard way is that as a practice, as a system, we have to initiate that discussion. If we don't, the patients don't want to talk about it. They don't want to think about it, and they would rather ignore it. If I could leave providers with one word of encouragement or challenge as it relates to colorectal cancer, I would just point them to the data and just remind them that colorectal cancer is the second leading cause of cancer death in the United States. It's the second leading cause of cancer death. I think that in itself, when you think about that and when you see that, should motivate you to pay attention. And secondly, it's preventable, right? There are lots of cancers out there that aren't preventable. And there's nothing that we can do other than try risk factor modification. But there's nothing you can do to prevent it. There's nothing you can do to prepare your patient for it. Sometimes it just happens. But with colorectal cancer, it can be prevented. And so understanding that it's the second leading cause of cancer death in the United States is important, and reminding that it is preventable. It is. And so keeping that in mind, there are strategies that exist, and there are ways for you to improve your screening rates, and it doesn't have to rely on just the provider by itself. So if we can have the provider just to focus on it and make it a priority, I think the system should come together to help them to be successful.